Thank you. Thank you for inviting me today. It's a great pleasure and honor to be here to share my clinical experience with this HTK cardioplegia in adult cardiac surgery. So these are the types of cardioplegia, and I prefer this custodial HTK. The reason is just Dr. Preuss explained in detail about mechanism of HTK, but as a clinician, I like this because as Dr. Preuss said, histidine has a very good buffer effect compared to blood. So we don't have to repleage in most of the cases. And also at the bottom, there's no additives necessary. So this is very simple. The perfusionist can just cool this solution and just give. You don't have to give any additives. So we can avoid any mistakes. And other area is a lower potassium, so that should be better for the endothelium of the coronary arteries. And it contains free radical scavengers and low viscosity, so the distribution should be better than blood-based cardioplegia. So those are the composition of the HTK versus St. Thomas, and this is HTK versus Delnido. So those are the extracellular composition. Delnido is an extracellular composition, so as Dr. Preuss said, buffer effect is much less. So HTK is superior in that regard. So this was quoted in the previous talk. This is the first randomized study comparing HTK versus cord blood cardioplegia from Norway. In this study, they used only 1 liter of HTK without any topical cooling or hot shot or anything. And then they just compared. And they found HTK group patient had a higher rate of ventricular fibrillation requiring cardioversion. That's not good for cardiac surgeons, but again, they used just 1 liter of HTK without anything. But despite higher ventricular fibrillation rate, they found no difference in enzymes, CK and troponin. And this is another randomized study for the isolated mitral valve surgery from Italy. So basically, they found no difference between the intermittent warm blood cardioplegia versus one-shot HTK. But they suggested if the patients have preoperative RV dysfunction, they suggested better to use topical cooling also to keep RV cold. And this is another study. This is HTK was applied for the minimally invasive mitral valve surgery, and they had very good outcome with HTK single shot in the minimally invasive mitral valve surgery through the right thoracotomy. This makes surgeons much more comfortable doing minimally invasive surgeries because you don't have to change the position, and you can avoid redosing the cardioplegia. And this study is also from Italy. This is about aortic surgery. And they also suggested HTK versus cord blood cardioplegia had a similar effect, although the HTK group had a lower 30-day mortality. And this is from Australia. They compared HTK versus tepid 28 Celsius blood cardioplegia for they call it complex cardiac surgery. Aortic cross-clamp time is about 140 minutes. And as you can see, no difference between these two groups. And recently, there was a systematic review of these articles And basically, they found, in terms of mortality, no difference between the HTK versus conventional cardioplegia. And enzyme seems to be a little lower with HTK, CKMB. And ventricular fibrillation rate was slightly higher with HTK. So I started to use this solution since 2007. And before I moved to Temple, I was at the University of Pittsburgh. And I used this, started to use this solution there. And these are the cases I applied this solution for. And I'd like to share some cases. So this is the first case. This was a 24-year-old lady, IV drug abuser. She had bad mitral valve endocarditis involved in both leaflets. So for this, we excised both leaflets, and we tried to reconstruct the mitral valve using autologous pericardium and bunch of Gore-Tex cores. So both anterior and posterior leaflets reconstruction. But after reperfusion, TE showed moderate MR. That was not acceptable. So we decided to replace the valve. So we re-cross-clamped and replaced the mitral valve. So the first cross-clamp took 131 minutes. For that, we used a single dose 2-liter HTK, antegrade, and then we put ice on the heart, and we used a hot shot before reperfusion. And after reperfusion, heart came back quickly, and we found moderate MR. So we re-cross-clamped, and this time it was also 51 minutes cross-clamp time. And we used, again, HTK 2-liter. And then after the replacement, patient did well. So she required minimum dose of inotropes, and ventricular function was normal. So I just wanted to say, some trouble can happen during the surgery, but even if you use HTK, you can always redose, and then you can do a salvage operation, and still heart works. And this was a tricuspid valve, prosthetic valve endocarditis case, 26 years old, IV drug abuse again. This was the specimen. So for this one, same thing, we used his autologous pericardium and a bunch of Gore-Tex cores. And this time, this valve worked. And cross-clamp time 100 minutes. And we used HTK 2-liter. And during the repair, we saw some electrical activity. So we added 1 more liter of HTK. And the micropreservation was good. This third case, this was an old patient, 84 years old male with low ejection fraction. Ejection fraction was 15%. And he had a critical AS and AI, and he was on the ventilator. So we did emergency aortic valve replacement. He was pretty sick pre-op. So for the cross-clamp time, 81 minutes, we used HTK total of 4 liter. Initially, we gave HTK through the aortic route, but because there is a moderate AI also, and so the heart didn't stop quickly, so we opened the aortic route and then gave selective antegrade coronary perfusion. But protection was very good. Ejection fraction improved to 40% from 15% pre-op. And this is another case. It's a 30 years old who had prosthetic valve endocarditis, and we did redo aortic route. This was a previous freestyle valve, and we enlarged the route and put the composite route replacement. And for this, we used a 2-liter HTK and cross-clamp time of 131 minutes. And this is a rather common case, AVR cabbage case, 79 years old male. We did AVR cabbage with a cross-clamp time 67 minutes. And this is pretty straightforward, 2-liter HTK, and no inotropes, no ventricular fibrillation, and good heart function post-op. And this is a left ventricular rupture case with, we did a cabbage also, but this was a chronic rupture and low ejection fraction, 30%. So this was the rupture based on the CT, and this is a actual rupture hole you can see. And with the HTK protection, we repaired this rupture and put bypass also. So I want to say, even for low ejection fraction, you can safely use HTK solution. And this is a unique case. This is a 25-year-old male who had primary pulmonary hypertension with severe mitral regurgitation and pulmonic valve regurgitation and the giant pulmonary artery aneurysm. So we approached through clamshell approach, and then we repaired mitral valve and pulmonic valve and did a double lung transplant. This is an intraoperative specimen and pictures. So pulmonary artery pressure normalized and did well. So, so based on these cases, this is at the University of Pittsburgh, we had eight cases whom we just used single-dose HTK antegrade. And another 10 patients, we used single-dose HTK plus we used hot shot before reperfusion. And we found with hot shot, you can reduce the ventricular fibrillation rate significantly. And now my cardio protection protocol is this. I use initially adenosine bolus injection, and then usually use 2-liter HTK, and I use ice on the heart just to keep the heart cold. And if we see myocardial activity, electrical or mechanical, we add HTK, and before reperfusion, I use hot shot. And I use adenosine because HTK's potassium is 10. So sometimes heart, it takes some time for the heart to stop, and adenosine can make it shorter. That's my bias. And this is our hot shot solution. This is before reperfusion to prevent ventricular fibrillation. So after I moved to Temple, I started to use HTK in January 2012. So to date, we used for 102 cases. Mean age of 60, oldest was 94 years old, about 50-50 male, female. And BMI was 29.8, highest was 51.5. BSA average of 1.96, highest was 2.76. So pump time average of 202, and cross clamp average time was 94 minutes. Longest was 195 minutes. And these are the procedures for these cases, mainly aortic valve cases, but we have some mitral valve, aortic dissection, adult congenital case, and then PTE. And this is a PTE case, 45-year-old female with a CTEF. As you can see, clots in the right PA. So for this one, cross clamp 137 minutes, and circulatory arrest time is 65 minutes. We just used a 2-liter of HTK for 137 minutes cross clamp time, but heart did well, and this was the specimen. So we had a 21 PTE case for the CTEF, mean age of 50. And we usually cool down at least 20 degrees, some cases up to 17 degrees. We make sure EEG becomes flat. and average pump time 302 minutes, and cross-clamp time 113 minutes, or HTK one shot. And circulatory arrest time is 59 minutes, and we use antegrade cerebral perfusion. So we didn't observe any low output for this 113 minutes cross-clamp time with HTK one shot. We didn't see no stroke. We lost one. So the mortality rate was 4.8% for the PTE. And then two more cases I wanted to show. This is a prosthetic valve endocarditis from outside the hospital. Patient was referred from outside the hospital where he had AVR 1 year ago. There was a significant perivalvular leak, and this was the intraoperative picture. You can see the dehiscence of the valve. So for this, we did the Ross procedure, and the cross-clamp time 126 minutes, and protection was single dose HTK, but we used a 3 liter because this is a selective antegrade coronary perfusion. There was some leakage, so we gave a little bit more, 3 liters. But the heart protection was excellent. Patient extubated day 1. ICU stay was 3 days only. And then the other prosthetic valve endocarditis was this case. This is a 58 years old IV drug abuser. Ejection fraction 40-45%. She had a severe aortic valve stenosis. This was the prosthetic valve endocarditis. Interestingly, she had a VSD also, so abscess cavity was pushing the tricuspid valve. So we repaired the VSD and Ross. So the total cross-clamp time was 156 minutes, pump time 314 minutes. But HTK protected heart very well and did very well. So all those we had three Ross cases for prosthetic valve endocarditis, cross-clamp time 144, but HTK worked well. So as a clinician, I like this solution because it's safe and efficacious and very simple. Thank you.